So for those that are on the call, thank you for joining us again. I'm super excited to be moderating this session, and I am Reed Plimpton, the Northeast Telehealth Resource Center Project Manager. I'm going to turn the controls over to our two speakers here today, Dr. Keith McAvoy and Caitlin Darling from Dartmouth-Hitchcock Medical Center, to talk about their topic.
Okay, great. Well, first of all, I wanted to say thank you to Reed and for all the members of the 2020 Launching into Telehealth conference for allowing us and giving us the opportunity to speak today. We're going to be talking about teleneurology and specifically physician burnout and provider burnout. So just a brief introduction to myself and my partner. I am Keith McAvoy. I'm the TeleNeurology Medical Center for Dartmouth-Hitchcock Medical Center. I'm physically located at one of the satellite clinics in Manchester, New Hampshire. Caitlin Darling is our senior practice manager and at the Center for Connected Care. I have no financial conflicts of interest to disclose. Although I don't have it listed on a slide, I just want to go over a little bit in terms of the objectives of the talk. First of all, I would just like to briefly mention Dartmouth-Hitchcock Medical Center in general. I would like to talk a bit about our teleneurology program in particular and some general advantages of teleneurology overall. Then I would like to focus on provider burnout. You know, what is it? And then maybe to offer some insights into how teleneurology as a service has the capability of reducing physician, provider, and particularly neurology burnout. So Dartmouth-Hitchcock Medical Center is an academic health system. It was named #1 hospital in New Hampshire in 2018 and 2019 by the U.S. News and World Report. There's a little plug for us. We have 5 member hospitals plus visiting nurse and hospice covering both New Hampshire and Vermont. We have many ambulatory outpatient clinic locations through both New Hampshire and Vermont, and we're serving a population of approximately 2 million people. You can see from the slide there are a lot of woods around that large medical facility. When I first went to Dartmouth decades ago now, I drove up there and it was miles and miles and miles of trees, and my thought was, where am I going? Where is this place? And after a few rights and lefts through the woods, it just opened up. It sort of reminded me of Dorothy and her crew seeing Oz for the first time, just opening up in the midst of the woods like that. So along that vein, Dartmouth Medical Center serves a very broad and a rural region. But despite that, they're a cutting-edge medical facility with a comprehensive cancer center, a level 1 trauma center. It has New Hampshire's only children's hospital, which is the Children's Hospital at Dartmouth-Hitchcock, abbreviated as CHAD. They have intensive care units for medical, surgical, a relatively new neurologic ICU, cardiovascular, neonatal, and pediatric ICUs. And essential to the functioning of both the medical center and, in order to serve that rural large community, helicopter and critical ground transport service, abbreviated as DART, which allows patients from this large region to be brought into the medical center when appropriate. So let's talk a little bit about our teleneurology service in general. All our teleneurologists that are involved in the program are board certified, and we provide coverage 24/7, 365 days per year to hospital emergency rooms, inpatient setting, ICU, other inpatient locations, not just for stroke, but we cover all sorts of neurological questions and concerns and consultations and issues. We try to adhere to best practices and protocols. We have secure, simple, reliable video conferencing equipment. And one of the focuses of our program right from the beginning is to try to avoid transferring patients. We've been really trying to keep patients located when possible at our spoke hospitals to keep them closer to home. And it also works to help minimize the costs of care for obvious reasons. In terms of our numbers, we have 11 clinical locations throughout Vermont, New Hampshire, and more recently Maine. Since its inception in late 2015, 2016, we've done over 4,000 TeleNeurology consultations, averaging about 800 per year. Less than 10% transfer rate at both community and critical access hospitals, which is significantly lower than prior to when TeleNeurology was initiated, which has really been a benefit, which I'll talk about a little bit later, to some of our associated community and outpatient hospitals. And our emergency TeleNeurology average time to video is 11 minutes. That's an average time, and you know, a lot of times it's much quicker than that, but that's our overall average. So we like to break our consultations into what we call emergent consultations and general consultations. Our emergent consultations we can further break down into what we describe as time-sensitive consultations versus non-time sensitive consultations. A good way to think about the emergent consultations are they happen in the emergency room. So you have both time-sensitive and non-time sensitive situations like that. And again, 24/7 coverage to the emergency room, including thrombectomy services at the main hub at the main medical center. The goal for the time-sensitive consultations is less than 30 minutes to consult initiation time. Again, there may be situations where there's multiple consults coming in simultaneously. So usually we do much better than 30 minutes for obvious reasons, trying to keep the door to window time as low as possible. For non-time dependent cases, maybe a change in mental status, for example, less than 2 hours. But again, it's much more often than that, much less of a time period than that. Some examples of time-dependent cases, patients would be acute ischemic stroke with a time less known well, less than 24 hours, a transient ischemic attack with onset less than 4.5 hours. But again, we do more than just ischemic stroke. We will treat patients who've had hemorrhage and direct them to the appropriate neurosurgeon, seizures, status epilepticus, myasthenic crisis, anything in the realm of neurology. Our general service is essentially scheduled patients, and again, we're talking about inpatient care here. It would be analogous to a general neurology service, for example, where you would be seeing consults in the hospital in person. So these are scheduled visits. They're completed within 24 hours. Again, oftentimes it's much sooner than that, but that's what we put our time limit as. And some general inpatient examples may be management of seizures, patients who are not actively seizing at the time. Headaches would be an example, change in mental status that may have been going on for hours or days, or follow-ups for patients who've already been seen for transient ischemic attacks or strokes. So let's switch gears a little bit and just talk briefly about what are the benefits of TeleNeurology for our patients as part of our spoke hospitals and care centers. Well, one obvious benefit or advantage, it will provide immediate access to emergency and specialty care that may not be locally available. So you can break that down and look at immediate access. So if we're getting contacted when we're on call for TeleNeurology, we are there in a matter of minutes. That's not always the case in an in-person consultation. You may not be physically located at the hospital. You may be at home at the time. It's going to take some time to get there. So having that immediate access is excellent. And again, we cover a rural area. So there are many of our spoke hospitals that just don't have neurology coverage at all. So it provides neurology coverage. Again, there's a shorter time to physician engagement during surge periods or busy periods. So we have a system where we have backup So if there are multiple consultations going on at the same time, I know that in my own practice, when we were covering the hospital, I may get maybe 3 or 4 consultations simultaneously. I can't be at 3 to 4 places all at the same time, but with TeleNeurology, you have backup neurologists that can cover if you're getting multiple simultaneous consultations. And to go back to the theme that I had mentioned earlier, it's going to reduce the chances of transferring the patient out, allowing more patients to stay close to home at the hospitals that they're currently located within. What are some benefits of TeleNeurology for consulting providers? Well, they have an additional resource. Again, rapid response to patient needs 24/7 or 365 days per year. A big advantage is having support with clinical decision making, and emergency room physicians or staff physicians like hospitalists, for example, have less of a feeling of isolation when they have a specialist there that can not only provide direction but support in their own decision making. And this is especially true, as a lot of you probably know already, from assistance with administering TPA. It's not always so straightforward given time constraints and stroke or TIA mimics. It's nice to have not only support but visual support on the part of the teleneurologist so that you can actually see the patient. In the bad old days, it was a lot of times just done by telephone, and it's not always easy to separate what may turn out to be a Bell's palsy from an actual stroke or a TIA. So having that visual component, especially a digital visual component, is huge. There's noticeably an increased focus on the patients with teleneurology consults. You, by necessity, have to have someone on the staff stay at the bedside to assist with the exam. So you're going to have a staff member above and beyond the teleneurologist that's providing you information such as labs, again, assisting with the exam, providing you vitals. So it's almost a little bit of a team approach, focusing on the patient in that way. What are some benefits for teleneurology for our spoke hospitals? Well, there's obviously, as mentioned, an improvement in patient care and avoidance of transfers, as mentioned, and that's going to improve not only patient care, but potentially the financial performance of the hospital. There's a decreased length of stay in a lot of cases because there aren't delays. I mean, if you're getting the consult done quickly and you're putting recommendations into place right off the bat, right off the beginning, you know, boom, 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 in terms of do this, do that, that may get things done quicker, reducing the length of stay for the patient. There may be a decreased need for a physician, PA, or nurse practitioner backup call, and I'm going to be talking about that a little bit later on. Reduced staffing costs, decreased need for hiring a locums to do coverage, lower cost or coverage for hospitals that have limited or no neurologic access. It is well known that the cost of having a teleneurology service in general is less than the cost of hiring a neurologist. It is less than the cost for paying the benefits to a neurologist. Generally, you're not going to just have one neurologist, because one neurologist is going to need to cover a hospital. They can't cover 24/7 all of the time. So you may need multiple neurologists, multiple salaries, multiple benefit programs. And again, to go back to what I'm going to talk about in a little bit, is that it may improve physician-life balance in terms of providing supplemental coverage, retention, and recruitment. If you're trying to, it's not always easy to recruit neurologists. There's a need for neurology. Neurology is hard. There aren't as many physicians going into neurology as some of the other specialties and subspecialties. If you can promote your program by stating we have teleneurology coverage for stroke and maybe at nights or weekends, that's attractive for some individuals. So let's go on to discuss the crux of the talk with physician burnout. First of all, what is it? what is physician burnout? It's always good to start with a definition, right? So it's a psychological, so first of all, there's many different definitions of physician burnout. I happen to like this particular one. It's a psychological state or a mental state characterized by emotional exhaustion, depersonalization, which I'll describe in a moment, and a lack of a sense of personal accomplishment associated with or caused by prolonged exposure to medical stressors. It's something that's chronic. I mean, it can be acute if you've had a bad call night, but it can be a chronic condition as well over time. It's common. It's very common. One study that I read, up to 1/3 of physicians, 33% of physicians in the United States experience symptoms of burnout at any given time. That is a huge number. Imagine that amongst all the physicians in the country, 1/3 of them feeling symptoms of being burnt out. I don't know that there's a whole lot of other occupations that can claim that. I'm sure that there are some, but I don't know if it's the same numbers. A Medscape Physicians Lifestyle Survey revealed that 46% of those who responded exhibited symptoms of burnout. So again, even higher than 1/3 in this particular survey, and it's not decreasing. Despite attempts to decrease it, it's actually up from 40% in 2013. So again, it's a very common phenomenon, but it's not commonly recognized. If you ask physicians, they may state that that's the case, but I don't think that the general public really knows that there's that degree of burnout amongst physicians in this country. What are some symptoms of physician burnout? Well, some of them are kind of self-explanatory and fairly obvious. So exhaustion, feeling tired all the time. If you're exhausted and you're tired all the time, that can lead to physical symptoms such as headaches, body pain, back pain, neck pain. Appetite may be altered. Either way, you may stress eat. You may not eat because you're too nervous to be hungry. There are sleep-related issues associated with being chronically exhausted as well. And this can feed, as you can imagine, this can feed in and become a vicious cycle, right? So if you're very busy all of the time, and you're burning the candle at both ends, and you're exhausted, and your body hurts, and you're having headaches, and you're not eating right, and you're not sleeping right, and you're still busy, what do you think that's going to do to all of those symptoms? It's going to exacerbate them. And it becomes, like I said, a vicious circle until something happens. Usually vacation. That's the usual thing that happens to help reset the bar, so to speak. You may experience symptoms of depersonalization. Again, some of these things are not recognized by the physicians themselves. That may manifest in different ways. It may manifest as cynicism, sarcasm, need to vent regarding patients or job. My God, this patient is driving me crazy. This job is driving me crazy. It's difficult, etc. And what do you think that does towards empathy? It decreases it. I mean, if you're struggling with job-related factors on a regular basis, it's going to be more difficult to be empathetic with patient concerns. You're focusing on yourself and the symptoms that you're having. Like this person in the picture on the slide, that may be someone in between patients or at the end of the day or after a long call shift. All of these things are going to impair efficiency, right? So if you're tired all of the time, if you're not eating right, not only are you going to become less efficient, you're going to have decreased motivational factors. It's going to be harder to go into work every day and deal with these things. So what are some of the common causes of physician or provider in general burnout? Well, one is the medical education system that we're all a product of, which focuses on working harder and showing no weakness. If you're not getting the job done, you need to work harder, and you cannot show any weakness. As I was putting together this slide, it brought back a memory of my first day as an intern in internal medicine and general medicine, where I was covering the intensive care unit, and my senior resident said to me, unless you have EKG changes, implying that unless I was having a heart attack, I expect you to be here. And that's the mindset. You know, don't show weakness. You're expected to be here under almost every circumstance. Also, there's the factor where, you know, patients, for the most part, and staff, they expect you to have the answers. They're coming to you, so you need to have all the answers. And God forbid that you make a mistake. Don't make a mistake. You can't. So you have to work hard. Don't show weakness. Have all the answers, and don't make a mistake, or else. And so that's, you know, whether it's conscious or unconscious, that's what physicians and other providers are walking around in the back of their minds. Another factor that contributes to physician burnout that I read in a number of studies is that there has been a trend in the last 10 years or even few decades. Most physicians nowadays in many parts of the country are moving away from the private practice model and becoming, including yours truly, becoming employees of large physician groups, organizations, and hospitals. And what does that do? Well, it decreases physician and provider autonomy, right? You have less control over your own practice. And what does that mean? That means that you will have a leader, and that leader may be a good leader, which would be great if that leader is supportive, a medical director, for example, or that leader may not be that great, may not be as supportive, may even be detrimental to your functioning, and that would be a major stressor in a practice. There's also different requirements nowadays than there were in the past. If anyone is as old as I am, they remember the days of paper charts where you wrote orders in charts and you wrote an order and then it magically happened. Whereas, I mean, you can still get that magically happen sensation with an electronic medical record, but there are lots of potential issues with electronic medical records. I could probably spend a whole hour talk on the electronic medical record, but obviously we're not going to do that today. But it is a different type of way to function in medicine than the old days. So you may have to click buttons to make sure you've looked at meds, looked at allergies. There's all sorts of things that over time become a habit. But initially, when you're first getting used to that, or if you change medical record systems, for example, it can be a definite stressor. And sometimes the medical record will shut down on you, and that can be obviously a problem as well. And to be fair, there are some advantages of medical records. I can take some of my work home, which then actually adds another stressor if I'm doing work from home as opposed to in the office. Another common cause of physician burnout above and beyond that are time constraints. There are many practices where the focus is to decrease appointment times. You don't have an hour with a new patient, you have 40 minutes with a new patient. You don't have 30 minutes with a follow-up, you have 15 minutes with a follow-up. And by the same token, organizations a lot of times nowadays are looking at factors such as patient satisfaction. So we want you to see more patients in less time, but make sure that patient satisfaction stays high. That's an obvious stressor. I don't need to explain that any further. It's a bit of a paradox, isn't it? In addition to a normal day, whether it's inpatient or outpatient neurology, you have meetings. Staff is coming up to you as you're trying to care for potentially complicated patients. Staff are coming to you for questions. You're dealing with other factors such as insurance denials. I think this would be a perfect medication for you, Mr. Smith. But you know what? It costs too much money and you can't have it. Or you do order it and then it comes back to you later. You need to do a peer-to-peer, which means more time to spend with an insurance company discussing or a radiology service why this particular medication or x-ray, etc. I'm probably not talking about anything that any of you have not experienced. These are common factors in today's medical practices, all sources of physician burnout. What are some other common causes? Well, it's just the nature of medicine itself. I alluded to this with the work harder and show no weakness. It's by nature of what we do, a high responsibility career. I mean, if you make a mistake, you can hurt someone, and not to sound overly dramatic, but there's always the potential for killing people, you know. So you can't be careless. You have to be a bit compulsive, and that's a day after day. With every patient interaction, there's some degree of that. And there's limitations on our control. I mean, there are things that happen with patients that are above and beyond our control. Maybe they didn't provide you with essential information and you didn't think to ask on that particular occasion. Maybe there was a pandemic that happened, you know, et cetera, et cetera. What about some specific stressors within a practice? Well, call schedule. You may have a light call schedule. You may not have a so light call schedule. It depends upon the nature of your particular practice, but that's a potential source of a stressor, and how that call schedule is set up. Do you get the next day off? Are you expected to be in the office seeing patients all day? Compensation formulas. Well, compensation formulas, well, if you, Dr. McAvoy, don't see this number of patients and do this number of procedures, this is what's going to happen to your salary. It may matter little to some practitioners, but it may not to some practitioners. It's just a potential source of stress. Local health politics, well, that goes without saying. There's always that in particular which can serve as a source of stress. Office personality clashes. Maybe you don't like your colleague. Maybe your colleague doesn't like you. But to deal with that on a day-to-day basis, again, a source of stress. What about life factors? Well, medicine is not a 9-to-5 job. We all know that. It's time consuming. And again, with the advent of electronic medical records, you can take your work home. You can go to work in the morning, start seeing patients at 7:30, have a meeting over the noon hour, see patients throughout the afternoon, go home, eat dinner, open up your laptop, answer emails, call patients, check on labs, compose letters, et cetera, et cetera. I'm not telling you anything that any of you don't know already. You can shut your laptop at 11 or midnight and do the whole thing again, and then through the weekend. There's the possibility of that, and trying to balance that care for patients, that responsibility for caring for patients with your life, your family, and other interests that you may have. Changing gears again a little bit, what about neurology specifically? Well, neurology in a number of polls has been ranked oftentimes in the top 5, sometimes in the top 3. This actually surprised me when I read this as one of the more highly rated specialties where physicians report quite a bit of burnout. And why is that? There's probably many more factors than I have listed here, and all of the general things that I said earlier would apply to neurologists. But in addition to that, neurologists address many conditions without a known cure. It's stressful to diagnose someone with multiple sclerosis. It's stressful to diagnose someone with amyotrophic lateral sclerosis or Huntington's disease, or et cetera. You know, someone once asked me, what is my favorite part of neurology? And my response to that was telling a patient that they don't have a neurologic condition. I don't want to tell them that they have something that we don't have a known cure for. We can address it, but there may not be a cure. What else? Well, neurologic conditions impact the essence of the patient. Not that a lot of other specialties don't, but in particular neurology. Patients with Alzheimer's disease, you know, someone who has had a heart attack, maybe a year later, you're going to talk to that individual and you're not going to know that they had a heart attack. They've been treated, they're doing well, they may be on a lot of different medications, but they're functioning and you wouldn't know from looking at them. A few years after you diagnose someone with Alzheimer's, you're probably going to know after a relatively brief conversation that they have Alzheimer's disease and other forms of dementia as well, and Parkinson's disease. Stroke the same way. Stroke is one of the most feared medical conditions amongst the population at large. You do not want to be impaired mentally or physically from having a stroke. It's readily apparent to most individuals who see the patient. The other stressor within neurology is that there are many diagnostic dilemmas amongst patients who may be poor historians. Neurology is a condition that entails a lot of fascinomas, meaning that's the term we used to use, a fascinoma. So someone who has an unusual neurologic condition that's not that common. So you have to figure that out, something that you're not seeing on a very frequent basis. There's a lot of genetic testing nowadays that helps assist with that. But you're also dealing with individuals, with patients who may be poor historians. So if you're taking that combination of a difficult historian and something that you don't see frequently and combining that, it can be a challenge, and it's a stressor. So you have to be on your toes intellectually. So what are some general strategies for burnout assistance? Well, fortunately, there are quite a bit of resources from membership organizations. For example, the American Academy of Neurology. So there are resources out there, and with the expansion of the internet, there's lots of potential sources that you can reach out to. If you are part of a large organization, sometimes they have employee assistant programs to allow physicians to approach them and discuss stressful situations and issues, which is very beneficial. Historically, and when I started in neurology, the neurologist essentially did everything, which meant that you would round on your inpatients, kind of like the days of the internists before hospitalists, where physicians would or providers would round on their patients in the hospital in the morning. You would see patients in clinic during the day, and then maybe have to cover in the evenings, whether you're on call or not, so to go back to the hospital for more consults. And if you were covering multiple hospitals simultaneously, then you would be doing the grand tour, so to speak, from one hospital to another, seeing patients there. So one trend that's happening now, and it's been going on for a little bit, is the hiring of neurohospitalists. We did that in our practice. That can cover the inpatient service while others in the practice can focus on outpatient neurology and outpatient clinic. They're very different animals. Inpatient neurology and outpatient neurology are very different. And I can recall having to make that mental transition if I was spending 3 weeks doing exclusively outpatient, and then I was on call, thinking differently about patients, because it's a very different type of practice. So neurohospitalists can really assist with that. And then finally, the concept of this talk was TeleNeurology. How can TeleNeurology assist? Well, really, what am I talking about here? I'm talking about kind of the same concept as a neurohospitalist. So I'm talking about having teleneurologists, for example, a program whereby you can use teleneurologists to cover, say, nights, say, weekends, kind of like you would potentially use a neurohospitalist. So the focus then again would be on time savings. It can reduce burnout by a more manageable work schedule, especially with call hours. If you have a supplemental program, if your practice can afford a supplemental program where your call hours are covered, maybe nights, maybe weekends, maybe some nights, maybe vacation, whatever, it's beneficial in that regard. And not just to talk about the inpatient setting, but from an outpatient setting, I mean, there's lots of different ways you can utilize a teleneurology service. You could even make your practice some days of the week you can focus just on teleneurology and potentially work from home. That could be a nice feature if that fits in with your practice. Again, on the outpatient side, it has the potential for providing more dedicated and consistent care. So, for example, you may set aside some dedicated time for just a teleneurology period where you can focus with outpatients that are not necessarily coming into the office. You could do teleneurology calls And what would that potentially do? It may decrease emergency room visits by increasing remote telehealth visits. You may be able to keep them out of the emergency room by offering them advice, for example. That's possible. So again, increased ability to focus on patient issues outside of the office. What may happen is that you may be able to set up situations where, again, if you have an outpatient teleneurology service, patients don't have to come to see you. That's especially relevant in a situation like where we are, where it's a rural setting, and patients may have to drive a long period of time to get to see us. So there's no commute with a teleneurology visit. You don't have to deal with parking hassles. I think some of my patients were able to avoid copays, but I don't know if that's the case. I'd have to look into that. I asked someone that the other day, who I was doing a teleneurology visit with. I said, do they charge you a copay? And the patient said, I don't know. So more to follow on that, I guess. And then in general, teleneurology provides increased patient access to care. So you can do this right from virtually anywhere. You're not limited by location. So you can potentially see more patients. You can see more patients more efficiently virtually. And what is that going to do ultimately? All of these factors with changing your practice by supplementing with teleneurology, it's going to improve access to care. It may improve patient satisfaction. We all know that if your patients are more satisfied, then the physicians and the providers are more satisfied. That's going to have a direct impact on burnout. If you have a lot of patient complaints, that wears on you, whether you're conscious of it or not conscious of it. When patients say to you, boy, I like this. I like how this is working. I like doing this with you. That's a positive reinforcer. That's a weapon against burnout. So before we get to questions, just some general statements. In conclusion, physician-provider burnout, it's very common, much more common than is generally recognized amongst providers. Neurologists in particular have a high rate of burnout. Teleneurology can reduce burnout by supplementing a practice for inpatient call coverage and strategies also for outpatient services. This is not a complicated concept. It's using teleneurology to fine-tune your outpatient practice, and it's using teleneurology to supplement your inpatient practice to give you a better life, to give you more energy, to reduce burnout. Better neurologist, a happy neurologist means better care for the patient. So this is, I look at teleneurology as really groundbreaking in a lot of different ways, but especially in this regard. And I'm going to end there. I have about 15 minutes or so, and I can stay longer if necessary to answer any specific questions that anyone has. And I thank you.
Awesome. Thank you, Keith. And Caitlin, thank you for being here and being ready for the question session. Just give me just a second here, and I will share my screen. We do have a little bit of a smaller crew here, and that's exciting in the sense that we have a few questions, but we also should have the opportunity to, can everybody see this?
I can see it.
Perfect. We should have the opportunity for folks to be able to, if you want to elaborate on your question so that Keith and Caitlin can understand it further, or if you have a question that's not here currently, we should have some time for folks to be able to unmute and come on, hop online with us, if you will. So in the spirit of that, we'll start at the top. How's that sound, guys? Do you have a process for training a newly hired provider or otherwise who is interested in joining your tele-team?
Yes, that's so the short answer to that is yes, we do. The longer answer is, well, one of the things that we're seeing and that we're actually involved with, and again, we have the advantage of being an academic center, so we have residents and medical students, etc. But I think more and more neurology residency and fellowship programs are including teleneurology in their training programs, either as an elective or some form of mandatory session where they can be part of a TeleNeurology, have the opportunity to be part of a TeleNeurology consult and to be involved in other different ways. But in our practice, when we bring patients on board, we make it voluntary. So if they want to be part of our TeleNeurology team, they can be, but it's not mandatory to do so. What I've found is that a number of the older neurologists in practice are less interested in it. I think that there's some potentially scary features of it. It's something different than what they're accustomed to doing. What if there are technical issues? What if there are this, that, or the other thing? I think that in most programs, including our own program, we have a 24/7 technical assistance by two really excellent individuals who can really help out if there's any sort of technical issues. Again, 24/7 they cover. But so if an individual does have experience in it, then it's really just showing them the nuts and bolts of our particular program. If they don't, then I'm usually responsible for going over it with them to show them how to do it. But I'll tell you, a lot of it is doing what you would normally do anyway, just on video. I think the biggest challenge is the examination, because everything else is fairly the same. You're going to have someone who's going to provide you information with vitals and labs, and that's actually kind of a nice feature. I don't have to dig those up myself. A nurse will provide those for me. But it's really training, I think, the nurses as to how to do, for example, an NIH stroke scale on video. In certain components, I found that training them, for example, to do a visual field test can be challenging at times. And other aspects of the exam that are beyond stroke, like reflexes and things along those lines. But we have an expanded team that's dedicated to training both providers and the ancillary staff in doing that. And that really is huge. I think it's really essential in order to have a successful program. You need to have that team as a backup. And that includes managers, technical people, and assistants in training. Training anyone who's going to be involved at both the hub site and the spoke sites.
That's a great answer, Keith. I think that's from multiple different levels. I think the last 3 months where a lot of folks have stood up telehealth systems, I think we have all gained a little bit more appreciation for that deeper level of technical assistance that's different than what Netric provides, right? It's the actual there 24/7 to help you with your platform, but also just the sort of team culture of learning and stuff. I think that's really awesome. But it also sort of leads a little bit into this second question here. Can you speak towards how your systems culture and your organizational flow factors into the willingness of some of your providers to have the conversation around burnout and sort of avoiding provider burnout?
Yeah, no, that's great. So again, it's as I had alluded to during the talk in one of my previous slides, it's a little bit of a paradox. And what do I mean by that? Our system, our system wants us to see. Well, first of all, I'll start off by saying that we're an academic center, we're a not-for-profit center. But if you are bringing in finances to the system, that allows you to do what? That allows you to hire more support staff. That allows you to build more buildings. That allows you to open more clinics. So there's an undercurrent. I mean, it's not looked upon favorably to do less. The culture is do more with less in a shorter period of time. So there's the basic background for burnout there. But again, in being fair to our system, we have, as I had alluded to earlier as well, an employee assistant program. So, and we get emails periodically. Hey, this person is the head of our employee assistant program. If you are stressed, if you are feeling burnt out, you can arrange for a confidential meeting with this individual to discuss these things. And I think that is hugely beneficial as part of a system. to do that because it really provides that support. Do a lot of providers take advantage of that opportunity? To be honest with you, I don't know. But it's there, and we're reminded that it's there, and that's what's the saying? You can lead them to the trough, but you can't make them drink. So, you know, provided that the system is supportive in that way, that they do have the resources to do that, reminding us that they're there. Those are all huge factors.
So the next one would be talking, and you touched on this in your slides as well, and I think that's what brought this up. The differences in how you're looking at workflow considerations when you're talking about teleneurology with inpatient versus outpatient.
Yeah, no, that's a really good question, and really an expansion on as you alluded to, Reed, about the talk that I gave. Yeah, I mean, there's a lot of differences, and I think, as I had mentioned, probably one of the greater advantages of the inpatient mode. I think one way to look at it is it really depends upon what the hospitals have, right? So I mean, we have hospitals that we're affiliated with, for example, that have neurologists. So I mean, they want to focus mostly on their outpatient practices. They don't want to be getting a lot of calls with consultations at nighttime and on the weekends. So there's an opportunity there, again, to supplement that practice. I think I beat that concept like a dead horse, but also I think that there are other situations where there's just no neurology at all. So you can actually serve with teleneurology as the neurology everything for inpatient. So is it as good and as optimal as having a person there? Well, it can be. I mean, I think it depends upon your service and who you have involved. There may be some limitations, but you can get a lot of what needs to be done performed by a teleneurology service, especially as it grows and expands and there's more experience. In terms of the outpatient teleneurology workflow considerations, again, as I had alluded to, I think you can utilize that in a lot of different ways. You could, for example, in the evenings I go home and I have phone calls with patients. Well, I can make those teleneurology calls, so it's not just a phone call for certain situations. So that may prevent a patient from having to go to the emergency room. Or I can make days of the week just my teleneurology days where I'm going to see outpatients that way. So it's a completely different workflow. You can do general consults, emergency consults in the inpatient setting, in the outpatient setting. You can use it supplementally in a lot of different ways, or just have scheduled patients like you would do in the office, except they're not coming to the office. They're doing it tele. Now, obviously, you have to have a system set up so that the patient's going to be able to do that. They have to have some access to your system by whatever means in terms of applications and whatnot.
So I might sneak a personal question in here right before the patient satisfaction one, because it gets to a similar thing. I think that's a really interesting avenue of telehealth encounters, right, is getting the patient the platform itself. And was that a little bit of trial and error for you guys, or did you have a pretty good testing process before you did so, or?
Yeah, that's an excellent question. And I'm sure this has been discussed in the conference already, but this whole pandemic has kind of completely semi-revolutionized how we're dealing with the outpatient service. I think we as a system, and Katie can jump in here if she wants. My recollection is we were doing as a system on average 9 outpatient consultations per day as a system. And then with the advent of the pandemic, I can't remember what the exact number is. It's hundreds, I think, of consults per day as a system, and it really got people thinking. Well, part of it too was that it's being paid for now, whereas before it wasn't necessarily going to be paid for on the outpatient setting, depending upon where you were, if it was rural or non-rural. But in addition to that, I think it really got a lot of people thinking, how can we use this service in a lot of different ways? So for example, if your office is short-staffed and you want to set up days where you have teleneurology days, well, I may not need a medical assistant or a nurse that particular day if I'm working from home or working off-site, seeing patients that way. Or what if, I've been saying this for years anyway, I have lots of patients in my practice that they don't really need to come to the office for me to take care of them. Like I have patients that have epilepsy, for example, that haven't had a seizure in 10 or 20 years. They come into the office, how are you doing? I'm doing great. Any changes? No. Well, let's do some labs and I'm going to refill your medication. But that's time, and I can't get those patients back to their primary care providers, even though they're stable, because their primary care providers don't feel comfortable prescribing those medications. And I get that. There's potential liability issues, or what if the patient's put on something else by another provider and there's a potential interaction? They don't feel comfortable dealing with that, and I get that. But by the same token, if I'm able to segment those patients in a teleneurology day, if that's possible, that may free up some staffing in my office. That may free up my parking garage. It may have a lot of different potential advantages in that regard. So I think this pandemic has been a terrible thing, but one thing it's kind of led to is a whole different perspective on telehealth, I think.
100% agree. And Caitlin, yes, please feel free to hop in with some insights on this or any of the questions we've had so far.
Yeah, I would say it was actually up to over 2,000 visits per day that we ended up moving to after those 10 visits per day pre-COVID. The other thing that we're finding really beneficial right now is as patients are coming back to the clinics, some patients still aren't comfortable coming back into a hospital setting for their visit. So telemedicine's been extremely helpful there, and also to help with social distancing within those clinics. So finding that right balance of who still does telehealth and who does the in-person visits, so that we're now not overloading, waiting rooms and exam space with too many people. So those have been the other, key benefits during this transition of the pandemic.
Sure. I think that's a great point in itself. I think it's interesting because teletriage is a word that existed before this, but that is sort of what I was thinking of it as when I've listened to some health systems talk about that, right? Is can you get a hold of your patient before they come in and do some of these lower level interactions and so on and so forth? That's really neat. I don't know if you guys noticed, but we did get a new question, which is awesome. And so I think, folks, we do have about, looks like about 6 minutes. So we can definitely get through this one. Feel free to put any other ones in the chat like this person was able to find back in the platform, or just raise your hand on the Zoom platform and I'll unmute you and you can come live with us for a few minutes. So to read the question, how do outside hospitals schedule or request virtual teleneurology consults with their non-urgent patients? Virtual rounding model? I'm not sure if those are two separate questions. I'm not as familiar with this as you guys might be.
Yeah, well, we have a transfer center. I'm going to let Caitlin as our manager field that question. It's a really good question.
Yeah, so we have a call center that works with us to help us triage all these calls that come in. So, we have our urgent model for teleneurology where you call, the transfer center takes the information, they page the neurologist connects to CART, and that's how the emergency flow goes. For the non-urgent patient, so it might be that you want rounding on the patient, so they've been seen in the ED and now you've admitted them and you want follow-up the next day, or there's a new issue going on with the patient, or potentially you want to discharge the patient home, but you think they should have that neurology follow-up discharge first, especially if the patient might have friends or family members that want to attend that visit to know what kind of, care should I give my patient at home. So for that model, the calls still come into our call triage center, and when they come in, we still take the same information down on them. And for the inpatients, we do like to try and request information on them, so overnight or while they're stayed there. have they had any recent labs done or imaging that would be helpful for more of an evaluation as opposed to a quick consult. So sometimes we will ask for some of that information, and then we will schedule that visit when it fits best for the patient. So we can schedule it the next day for certain time frames if you know family members are going to be there, or if the provider who is, discharging the patient wants to be there, or the provider working with the patient, we work with them to figure out what is the best time for this visit to happen. And then, 15, 20 minutes prior to the visit, what we do is we'll call and just give a reminder that the visit's going to happen, and then the neurologist will connect. So it's more of a scheduled inpatient process that will follow for that.
That's really neat. So it's akin to sort of like a warm handoff in some of the behavioral health models. That's cool.
Yeah, absolutely. And then I don't know if we may have answered it already, but the question before, do you have examples of patient satisfaction stories or more aggregate level insights? So on a number of different levels, we have many examples of the hospitals that we're affiliated with. A lot of the staff, and especially the emergency room physicians, that are very thankful for us. Again, it's not always easy to recruit neurologists, especially in a rural setting. So there are many emergency room physicians that have provided me specifically with feedback that said, we really like your program. We really like what you're doing. They may have insight into what to do already, but just having that support from a specialist via video to tell them, yes, you're doing the right thing. I don't have a whole lot to add, but you may want to do this, that, or the other thing. I mean, that is huge for them, and it is so much better than the phone way. I mean, again, doing it by phone in the bad old days, you hang up the phone and there's always that lingering, you didn't see the patient. You may not have had a conversation with the patient. So I think patients who aren't exposed to it may think it unusual at the beginning, but they get good care. They get better care, I think, than in the past in many respects. And on an outpatient setting, as Caitlin had alluded to, this whole business about the social distancing and the exposure. Many times, many of my patients have said to me online, I am so glad that you had this available for us. Because, I mean, imagine what we would be doing if we didn't have this. We would either not be seeing the patient, dealing with their issues by telephone, or having them come into the office. And, so this is just such a huge beneficial tool to have on a number of different levels.
I'm really glad you revisited that, because I think you did a great job of hitting on some of the more intrinsic value points that have become like more palpably important throughout this PHE, right? Like just the fact that we can get the video to the patient allows for a more comprehensive interaction. It's truly an increased access to care. So that's awesome. I will say, I mean, if you guys have closing up thoughts, you're welcome to share them, but also we do have time. If anybody has one more question, feel free to throw it in there or unmute and share. Or if not, Keith and Caitlin, if you have any sort of parting thoughts of wisdom that you'd like to share with us, I would definitely welcome them.
My only thought is thank you again, everyone, for the opportunity to let us speak. I hope it was enjoyable from your end. It certainly was enjoyable and a learning experience for me in terms of recognizing the amount of burnout there is out there. Anything that we can do to reduce that amongst our providers, the better, right?
100% agree. A great talk on multiple important topics within the same thing. So I hope that folks have learned as much as I did. And I'd like to also thank you, Keith and Caitlin, for fitting this in. I know that you guys worked with me quite a bit over the last few months to transition our plans from speaking in June in New Hampshire to doing this online. And I'm grateful that you were able to attend. For those that are still hanging out right now, you've got about 10 minutes until your next breakout session. There's some time to check out some of the virtual vendor interviews and prep for the vendor hall this afternoon. Like I said, I'm happy to hang on for a few minutes here if somebody would like to unmute and introduce yourself or ask a question quickly.